Thank you for joining me again today. I love doing these shows. It never gets old for me. Literally, I look forward to being here and answering your questions. So thank you for sending them in. And some days are easier than others as a fertility doc. I try and sparkle as much as I can, but as you can imagine, a lot of the time I'm giving bad news. A lot of the time I'm giving good news. And I just know that there's always hope for all my patients who come and see me. So for those of you guys who are joining me, I know you're joining me because your journey is not over, but thank you for believing in love, and thank you for doing one of the most selfless things, and that is becoming a parent. I have patients that say, oh, I know, doctor, I don't want to be selfish, but I really want 2 kids. And I'm like, that's actually the definition of selfless. Bringing children into this world, especially in this current environment, I don't think that there's anything selfish about that. So keep doing what you're doing. And I hope you're going to learn a lot from today's Ask the Egg Whisperer. So go to asktheeggwhisperer.com. That's where you can enter your questions. And then Paula will be sure to email you so that you know which session your question is going to be answered in. So thank you guys again. Before I get into the questions, someone said something to me today, and I think of myself as this, like, believe it or not, I actually think that I'm good at one thing, and that is, aside from making momlets, being a good communicator. And someone said this to me, and I said, that's something I need to teach you guys. And what this patient said to me, she said, Dr. Aimee, what have you ruled out? And I was like, that is a very good way of you guys asking your own doctors to make sure they've thought of everything. So for me, I have all my mnemonics, right? I have the Tushy method, the balls method, the angel approach, embryo diamonds. Like, I go through this stuff. I'm always making sure I'm not missing anything. And I do my best to communicate with my patients through verbal communication, email communication. So I try and reinforce what I say, because I know that it's easy for me to say these things because this is what I do and understand because this is what I do all the time. But I know that if I was on the other side of the table, so to speak, it would be hard for me to understand these concepts if someone just said it once and then never said it again. So I found that their way of saying that was another way to get a doctor, a nurse, or your team to kind of teach you about what's going on with your body. So what have we ruled out? A lot of patients are given the explanation of unexplained infertility. And so asking what have we ruled out is a nice way of saying, can you please provide me a diagnosis? Can we talk about what the prognosis is based on my diagnosis and what treatment options do I have? So I hope you guys learned from what I just said. So let's dive into the questions. Here we go. So I have Suzanne's question. Thank you, Susanne, for sending this in. Her question is, hello. Hi, Susanne. I'm only wondering if you think that it's very bad to work night shifts when trying to get pregnant with an embryo transfer. I also work some days and evenings, but mostly nights, and I've heard different things about it, if it's good or not. What do you think about it? Can it really disturb implantation and cause miscarriage? It's not so easy to just change jobs or working hours. So Suzanne, I think it just really depends on how long you've been trying. So if it's been more than 6 months and you're over 35, I would say maybe, switch shifts. If you haven't been trying for a really long time, I don't think you automatically need to change your work schedule yet. But I would say if there is an issue and you guys are finding it harder to get pregnant, perhaps changing your work shifts would be something that I would suggest that you do. But off the bat, if you're trying to prepare for pregnancy, which it sounds like you are, I don't think you need to change your shift. However, if you were a patient of mine and I saw you for the first time, that it would actually totally be one of the first things that I would do. And I would tell you that, and I would say, what kind of letter can I write for you so that hopefully your work would understand and help us out with that shift. No pun intended. Okay, so this question is from Lindsay. Hi, Dr. Aimee. I'm a 27-year-old with no fertility or genetic concerns. However, I just came off a second failed medicated IUI. We did 5 milligrams of letrozole for 5 nights, then an Ovidril trigger shot, then 200 milligrams of progesterone after both IUIs. The tushy was checked. Love it. And doctor says my numbers were ideal each time. AMH of 3.7, 10 millimeter lining, and 1 22 millimeter egg on both sides. So now I'm starting to wonder if my donor's sperm is the issue. The first time the total motile sperm was 28 and the second time was 21 with a motility of 49%. My doctor said these are excellent numbers, but I've heard women with donors with a total motile count of 70 or more. I really like this donor in the sperm bank, but I'm wondering if it's time to try a new donor. My doctor seems to think that I just need to do a couple more cycles, but I can't help but wonder if there's something else I should be doing to improve my chances of implantation or fertilization. Okay, Lindsay, so here's what I would consider. It sounds like you're doing a medicated IUI and you're doing it the exact same way that I would do it if you were my patient. In cases like yours, a couple of things that I would consider. Thing one is consider doing a double IUI. So order 2 sperm vials and just do 2 IUIs separated by 24 hours apart. So let's say, for example, today is Thursday night, you do the trigger shot tonight, then I'll do 1 IUI on Friday for you, 1 IU on Saturday, and see if that helps. And then certainly switching donors is also another strategy, but I'm not worried about the sperm quality parameters that you shared with me. They actually sound pretty fantastic, but we know that frozen sperm is not as viable as fresh sperm, so get more sperm in there. Sparkling sperm. More of it. Okay, this question is from Jane. Hi, beautiful doctor. Thank you, Jane. I think I paid you to say that. I'm 42. I had a natural pregnancy in 2019, but at 18 weeks was diagnosed with trisomy 21. And then I made the tough decision to end the pregnancy. After that, I've tried to conceive naturally, but it didn't happen. So my husband and I went for IVF. My doctor never gave us a diagnosis. I had 13 eggs retrieved, 5 fertilized, all arrested on day 3. This was devastating. My doctor believed the eggs are not good quality. What should I do? Should I try IUI? I can't afford IVF anytime soon. Thank you for all you do. Jane, I'm really, really sorry. Like, so sorry that you've gone through so much. So this is the thing. At 42, it's actually totally normal to have an IVF cycle that you just described. That's the diagnosis. You have 42-year-old eggs. It doesn't mean that there's anything wrong with you. You're not missing anything big picture. But I would certainly look a little bit deeper into the sperm. Maybe do a sperm DNA fragmentation test. Look at all the supplements that you guys are on. Prenatal, vitamin D, fish oil, CoQ10 for you. Consider adding NAD, pterostilbene. You guys know my go-tos when it comes to supplements. And same thing for your husband. Consider having him on a male fertility supplement as well. And then my approach in a case like yours is let's be as aggressive as you feel comfortable being. It sounds like financially doing IVF again in the near future doesn't sound like something that you can do, but track and trend your fertility levels, look at your FSH and estradiol and AMH, and then keep showing up. I mean, obviously the problem with getting pregnant and having a miscarriage is that it cuts into your fertile life. But, you know, anytime a woman says, I want to get pregnant, unfortunately things can happen that are completely out of our control. So I think it's still okay to believe that you have a healthy egg left, even after the IVF cycle that you've experienced. I've certainly have had patients who've had that, but I would talk to your doctor about what the realistic expectations should be from future treatments and whether you should start considering more creative family building options like egg donation or embryo donations. They're both great. So, I mean, great, you know what I mean? Like, I wish I had something greater than that, like take this pill and you'll grow more eggs and your 42-year-old ovaries will be like 32-year-old ovaries. Until then, we still have some pretty incredible options that we can have women consider, and they can have beautiful families. So start talking to your doctor about that so that you can be a parent sooner and a patient less soon. I hope that made sense. This question is from Sangeeta. Sangeeta says, I'm an ardent follower of your channel. Thanks for the wonderful job you're doing. I'm 38 years old with low AMH and blocked tubes. Gone through 1 round of IVF with a fresh day 3 transfer. Although I had 3 A-grade embryos, the cycle failed, and I'm currently going through my 2nd round. I have 2 AA-grade day 5 blasts frozen this time. My embryo transfers planned next month. Please advise if I should transfer both or freeze 1 and transfer 1, considering my age. My doctor is advising both to be transferred. Okay, so you guys know my personality. Step 1, why are your tubes blocked? Is it endometriosis or is it from infection? If it's endometriosis, make sure you've asked your doctor, has my endometriosis been addressed before I do a transfer? I would hate for you to ask that question, transfer both, or ask that question after you've transferred both and have them say, oh yeah, you actually had mild or moderate adenomyosis, and then you missed an opportunity to treat the endometriosis or adenomyosis before you transferred. So I would consider, if you have the option to do it, implantation testing, consider doing the ERA test and the Receptiva test if your doctor agrees. And then I would say at your age, it would be my preference to consider and at least talk about transferring 2, but I do think that your chances are just as good as if you transfer 1 at a time. And one of the strategies that I use that I think is really helpful is on the day of the thaw, we just transfer 1, and then we take a look at it. If that embryo is sparkling under the microscope, and you know I love to say that word because it just makes me happy. If that embryo is literally just sparkling and sparkles up the room in the lab, then just keep it to 1. But if the embryo is saying, I probably will have a less than 50% chance of turning into a healthy pregnancy because of the cellular structure and how the cells look under the microscope, then transfer that second one and then transfer both at the same time. So that's how I would think of your case. And I'm glad you asked this question. And so talk to your doctor about it a little bit more and bring up the stuff that I just mentioned. So this question is from Brittany. Hi, Dr. Aimee. I recently went to the doctor to get an MOT so that I can begin freezing my eggs. You guys, I don't know what MOT means. Does anyone know what MOT is? I feel like I should know. It's kind of like LOL, and I feel like I should know what that is, but I don't know what MOT is. I'm going to keep going. I'm 33 years old and physically fit. I don't drink or smoke. My AMH results came back at 6.41. I had 33 follicles. I'm concerned that those numbers are so high, but the doctor said they're still normal, just above average. I have regular 28-day cycles. My menstrual cycle lasts 4 to 5 days, in which I only have cramps on the first day. I have a couple small uterine fibroids, but the doctor didn't mention any cysts. Are these numbers actually normal, or does it seem like something might be wrong? Thanks for your help. Brittany, you are blessed with lots of eggs. I think every diagnosis is a blessing because it helps us learn about our body, and you know that saying, knowledge is power. And so the fact that you have this blessing in your life, I wouldn't go looking for something that's wrong. This is amazing. Not everyone has follicles, a follicle count of 33 at 33. I mean, wouldn't that be cool? That would be really cool. I just came up with this. Every year you age, you take a drug that will increase your follicle count. Because if you think about it, women are waiting longer and longer to have their babies. My grandma had my mom basically as a teenager. My mom had me in her 20s, and I didn't have kids until my 30s, and I don't think my kids are going to have kids until their 50s. So one day, we'll hopefully find a drug that can do that for us. So at 33, having 33 follicles is pretty incredible. So I would count your blessings and know that that doesn't mean that anything is wrong, especially because you have nice regular cycles. Sometimes we think of conditions or situations like PCOS, which I call hope syndrome, which is a situation where women have ovulatory dysfunction because the brain isn't signaling the ovary in a balanced way. So I don't think you need to do anything to treat anything that you don't have, but I would just tell you, take CoQ10. Especially if you're considering having kids later in life. Even if you freeze your eggs now, I have a sense that you probably won't need them unless you want to have kids over the age of 40. And even then, you probably will be one of those people who could have a baby over the age of 37. I can't guarantee your pregnancy at 40, but my sense is that chances are good that you will be able to. Okay, so this next question is from Steph. Hi, Aimee. My name is Steph. I'm 27. My husband and I have been trying to have a baby for 5 years. 2 of those 5 years, I didn't have a period due to hypothalamic amenorrhea. In the last 3 years, I gained weight, and now I have a normal BMI, and I got my period back. It's irregular, though, 35 to 60 days. My AMH was good, and tubes are clear. I did 5 rounds of letrozole without success. We had 1 round of IVF using ICSI. I had 9 eggs retrieved, 2 mature, 2 fertilized, 1 blast that was transferred and failed. My partner had a normal semen analysis and morphology. Do you think our problem could be an egg quality issue? My lining was also 6.6 millimeters before the FET. In the next round, my doctor wants to do a mixture of FSH and Menopur to try and get more mature eggs and increase estrogen to improve my lining. Any other suggestions we could do to optimize our success? So what I would say is let's break down the diagnosis and really make sure the diagnosis is true and accurate. It sounds like maybe your AMH might be on the low side. And so let's reevaluate that and take a look at your FSH, estradiol, and AMH. And so if the diagnosis is more an egg story, let's do everything we can to support your egg quality going into another cycle. So we talk about things like your environment, your lifestyle, the supplements that you're taking, the foods that you're eating. So make sure you're maximizing all of those things. And I know I say the supplements over and over, so I'm not going to talk about those again. And then also look at the sperm quality and the genetics of the sperm. Perhaps consider doing a sperm DNA fragmentation test, if you haven't already, to see if that would increase the blast formation rate and the likelihood of a higher fertilization rate. Because your fertilization rate, I would say your maturity rate is low, your fertilization rate was pretty awesome. So I'm not sure that sperm is necessarily the culprit. So I would say that in my experience, in a case of yours, I would say that consider doing a dual trigger, or at least a double trigger shot. Make sure they're giving you enough of the HCG hormone to induce maturation of the eggs, and also make sure they're pushing your follicles large enough so that more of the eggs will be mature. So rather than triggering you at like 16 to 18 millimeters, maybe even consider going past 18 and trigger at 20 to 22 millimeters. That might be a great strategy for you to get more mature eggs. And don't give up. I still think that you have a really, really good chance of pregnancy, especially with your age at 27. And then just a couple things real quick. Make sure you've done a chromosome analysis for you and your husband. Sometimes young people, we wait too long to do some genetic tests that we do on others, and it would be really annoying to find out that you guys carried, let's say, a balanced translocation after going through more treatments. Chances of that happening, super low. But still, it's an easy thing to do. It takes about 2.5 weeks to get results back. And lastly, with your lining, so we know the diagnosis, maybe an egg story and the hypothalamic amenorrhea. We know exactly how we're going to prepare you for IVF and what we're going to do, increase the menopur, increase the dose of meds, and add more HCG. But when it comes to embryo transfer preparation, I would not transfer with a lining less than 7 millimeters. So I think your doctor's strategy of doing what they can to increase the lining before they do a transfer would be awesome. Okay, great question. Okay, now we have Tiffany. Tiffany's asking, I've learned a lot from your videos. I'm not as intimidated about potential infertility because of them. Thumbs up. I've not been able to confirm ovulation since I began tracking BBT in May. I have mildly irregular cycles, range of 17 to 37 days. Prolactin is high at 63, AMH is 10.7, BMI is 21.5, I'm 27, LH is 15, FSH is 7, when tested on day 29 of a 37-day cycle. I've never had androgen or ultrasound testing. The OBGYN was wishy-washy on whether or not I have PCOS and said to just recheck prolactin in 6 months. Does a diagnosis of high prolactin preclude a PCOS diagnosis? More importantly, what can I do to lower my prolactin to begin ovulating? And I'm worried to try Vitex in case I do have PCOS and don't want to raise my LH. I began eating healthier and exercising more. I want to conceive next June. Okay, Tiffany, you sound like someone who is doing the right thing by getting all these levels checked pre-pregnancy. Your prolactin level could totally be mucking up healthy ovulation, and there are really easy ways to fix a high prolactin. There are medications like bromocriptine, for example, that you can take. So if your OBGYN it's not a tool in their toolbox, easy. Medical endocrinologists can help you. This is something that they do all the time. And it does sound like you have lean, LEAN, PCOS. I did 2 interviews this past weekend. Please go back and watch them if you haven't already. Dr. Sasha Hackman, and go to her website. She's all about exercise and infertility and strength training and eating right. And it sounds like you know all of these things, but I think she's fabulous. So please be sure to go to her website. And then Dr. Dylan Cutler, I talked to her as well. She's also a PCOS coach. And I think you can relate a lot to what they share about their own personal PCOS story. And I hope that the things that they share will help you. So I don't think you have to be wishy-washy about it anymore. I know you're not being wishy-washy, but I do think that that's what's going on. And I think you can heal your PCOS by fixing some of the hormonal imbalances and doing all of the fabulous things that you're doing. And you may not need a fertility doctor. Maybe just fixing the PCOS will help you pinpoint and track your ovulation a little bit better. So this question is from Terry. Dr. Aimee, I wish I found you before my failed cycle. I'm 42, just completed IVF, and my embryo failed to implant. My AMH is 28. It sounds like the units are different than what we use here in the US. My egg retrieval, I got 14 eggs, 8 turned into embryos, 1 was normal, it was a 3 BC, and 1 is mosaic. I have fibroids on the outer wall of my uterus, 14 centimeter, 9 centimeter, 5 centimeter. Do you think my fibroids are affecting implantation? I also had 2 IUIs that failed and never have been pregnant and have hypothyroidism medicated with Synthroid. I also did a saline sono and my cavity is good. Any feedbacks or thoughts? Any feedback or thoughts you have would be appreciated. Thank you. Okay, so I have a 5 centimeter rule, a 5 centimeter rule when it comes to fibroids. Your fibroids broke the rule, they go in a jar. So having a 14 centimeter fibroid, automatically that fibroid goes in a jar. It does not belong in your uterus at the same time as a baby. It can wreak havoc on a pregnancy. It can cause preterm labor, preterm delivery, miscarriage, all the things you don't want. So if you are my patient, I would say this: let's do another IVF cycle, because you have to heal still from the uterus surgery, and you're not going to want to be hobbling in to see me right after the uterus, the myomectomy surgery. So I would say, let's do another IVF cycle. Let's get those fibroids out, and let's wait about 3 months, depending on what your surgeon says, to get pregnant. It sounds like you probably still have your mosaic embryo. Don't throw that mosaic embryo away. You guys all know what I say, right? Mosaic embryos still have a good chance of turning into a beautiful baby. Every fertility clinic in the US and all over the world should have a protocol that they communicate to you about when it comes to reporting and transferring embryos. So if you guys don't know what that is, before you do PGTA testing, PGTA, it sounds like I'm making a word up, but I'm not, unfortunately. It's I don't know why. I know why it's called PGTA, but it's a mouthful. Ask your clinic, as part of your process of going through IVF, make sure you find this out ahead of time. And if you don't know what embryo diamonds are, be sure to go through my Instagram feed and find the definition, because it's super important that you guys know everything about your diamonds before you start transferring. Okay? So thank you, Terry, for that question. So this question is from Pri. Pri is saying, I'm 31, 5'3", 115 pounds. My doctor previously didn't agree to transfer 2 embryos but I'm considering asking him again. In my first FET, I had a biochemical. My second, I had a miscarriage at 6 weeks after a subchorionic hematoma. I'm thinking if I transfer 2, maybe if both stick, at least either one of them will stick through. Even if transferring 2, will I increase my chance of live birth? Even if it's by 0.5%, I want to do it. What are your thoughts? Okay, Pri, let's get a thoughtful and thorough workup done. So you guys all here have probably heard about my angel workup and approach. You need the angel workup, okay? We want to look at autoimmune stuff to see if, let's say, adding Lovenox would be something that we should add to your protocol. We want to look at the anatomy of your uterus and make sure that you don't have a uterine septum. Look at your nutrition and make sure you've ruled out celiac disease, for example, and that you're getting enough folate. From a genetic standpoint, if you haven't done this yet, you and the sperm source should both get your chromosomes checked and also do a genetic thrombophilia panel. Make sure you're not a carrier for, let's say, factor V or something else like prothrombin gene mutation. So those are pretty basic things that we do for women who've had 2 miscarriages. So I would say you definitely qualify for a very thoughtful workup. And if someone says that you don't, just tell them, Dr. Aimee says I do. I wish that worked. But you can also use the strategy of saying, can you tell me what you've ruled out? And then you can say, well, it sounds like you haven't ruled out antiphospholipid antibody syndrome, thrombophilia, genetic thrombophilia, uterine septum. You could say that. So just go in with your checklist, go in informed, have your binder, and then make sure you ask all the questions that you need to ask before your next transfer. And then if everything else comes out great and there's nothing that you would do differently and your embryos are gorgeous, then I would say still consider transferring 1 at a time. But if you were my patient, I would definitely say after 2 transfers with the experience that you've had, I would go ahead and transfer 2 in your 3rd transfer. Okay, so this next question is from Elizabeth. Hi, Dr. Aimee. Thanks for everything you do. You've been an inspiration throughout this process. I'm currently 40 years old. I've done 4 IVF cycles. My first IVF cycle produced a normal 4AA embryo, but the FET did not work. I did 3 more cycles in another clinic, and I have 3 PGS normals and a low-level mosaic from the original cycle, and I'm ready to transfer. I have 2 questions. My second RE has done a number of tests, including the beta-3 integrin test, and does not believe I need to do an ERA. Would you recommend a natural or medicated cycle, or does it matter? And second, are there any supplements, foods, or suggestions to prepare for the FET? I've heard of HCG wash or Neupogen can be helpful. I'm concerned about another FET failure. Okay, Elizabeth, you're 40 years old. You've worked really hard for your embryos, and we know that our fertility declines after we're born. Okay, so I am not taking your embryos for granted. I'm just not going to. You've already had 1 embryo transfer that didn't work, and the embryo is gorgeous. What are we waiting for? Please just ask your doctor. Just humor me. Can we just do the ERA test and just make sure it's exactly the way we think it would be? I don't want to miss an opportunity to help you before you transfer yet another gorgeous embryo. I think sometimes what we do is my strategy is, let's talk about what would we do if this next transfer didn't work. And the thing is, if you don't do what you were going to say you were going to do up front, you end up transferring one of your best embryos yet again. And then let's say by the time you get to the point where you've done this type of evaluation and workup, now you're left with lower quality embryos. That's just not fair to you. You're 40. The likelihood of making more embryos, let's say in 6 months or a year from now, especially the number of embryos that you've described that you have, is going to be a lot lower. And these are your embryos. They're the most precious thing to you, as they are to me, as they are to your family. I should be like singing as I'm saying that because it seemed to rhyme, but you know what I mean. Okay, so I think it's okay to say to your doctor, can we just still do the ERA test and maybe also consider the Receptiva test and just look at my cavity again, do my preconception labs all over again. Just make sure I don't have a thyroid problem. Let's make sure my vitamin D is good. Let's just do all that stuff. Just kind of just take it back a step. A lot of people would say, but you just transferred 1 embryo. And I'm like, I know, but you worked really hard for that embryo, and that embryo had at least a 70-75% chance of implanting. So you just want to do your due diligence so you don't look back and be like, why did I not check that stuff before I did my second transfer? It's easy to say than do, but I think going through a transfer that doesn't work is really, really hard on us. So that's why I'm bringing this up right now. Okay, so this next question is from Sarah. Sarah is saying, I'm 35 years old with an AMH of 0.4 with a retest pending. I underwent 1 egg retrieval with a protocol, and this is the protocol. 5 days of letrozole and 300 units of gonal daily, and I produced less than 2 follicles, resulting in a cycle cancellation. My doctor at the time had me on a round of birth control the month prior. I had a better response on letrozole alone used for an IUI than when she put me on birth control pills. My former doctor recommended donor eggs, but we have now switched to a doctor we feel more comfortable with who advised our other protocols to try before we move to donor. Questions are this. I've read the higher levels of gonal do not yield any better stimulation outcomes. Given my situation, what would your recommendation be as far as a protocol? Also, would you recommend I go on DHEA to improve outcome? Okay, Sarah, this is the thing. It sounds like you're doing the right thing. You're checking your AMH again to see what's going on. I would check your FSH and estradiol as well and do another follicle count. And it sounds awesome that you're with a doctor that believes in your fertility just like I do. So at 35, you have 35-year-old eggs. You don't have the eggs of a 45-year-old. You might not have as many eggs left, and you're going to, based on your level, you might run out by 45, but hopefully you'll be able to achieve your goals in the near future. So my approach would be no birth control pills, natural cycle start, and consider possibly a hybrid approach depending on how many follicles you have at the start of your cycle. If it looks like your follicle count is similar to what you had before, then I would say doing a combination of high-dose letrozole with Menopur would be great. And gonal does grow eggs. It just sounds like you were over-suppressed from that birth control pill. And there's cycle-to-cycle variability. I just sounded like a boy going through puberty. There is cycle-to-cycle variability. Sometimes you just see a sign in a cycle that is like, stop. And you just stop. And it sounds like you did. And your body was like, I don't like these birth control pills. And actually, I'm going to have someone on here in the near future. We're going to talk about his research and studies that he's published, looking at how bad, and I'm putting words in his mouth, how bad birth control pills can be for a lot of women who are going through IVF. And it really decreases the number of eggs that we're able to retrieve. There are lots of perks, though, for birth control pills. I consider them fertility planning pills as well, especially for women who have lots and lots of eggs. They can also suppress the ovaries enough that they don't have a complication called severe ovarian hyperstimulation syndrome. So to further answer your question, given your situation, I would also consider DHEA, but it really depends on your body size and if you have any other metabolic issues. So DHEA micronized 75 milligrams, Theralogix makes a brand. You can use code all caps Tushy, TUSHY, but I also think for the PRC price, but I also think, CoQ10, True Niagen, Pterostilbene, ask your doctor about HGH and see if they'll allow you or believe and have seen other patients benefit from HGH priming, so taking it twice a week. I almost said deek. I don't even know what that is. Well, I do, but not pronounced like that. So twice a week until your next period start. But you're doing all the right things and you're asking all the right questions. And maybe consider adding acupuncture as just another cheerleader on your squad. Look at your diet, look at how much you're sleeping, think about what other mindful stuff you're doing as far as meditation and prayer. Okay, so I'm almost through the emailed questions, but not quite yet. So I'm hoping to get through all the live chatted questions that you guys have for me. Until then, I'm going to take a drink of my coffee. Okay, so this question is from Jenna. Jenna says, Hi, Dr. Aimee. I thought it said, hi, I'm Dr. Aimee. I'm like, cool, another Dr. Aimee. I'm 42, no kids, 2 second trimester miscarriages. Oh my God, I'm sorry. That is hard stuff. From naturally conceived pregnancies, diagnosed with Hashimoto's. No symptoms of endometriosis, never diagnosed. I have 2 normal PGS tested embryos. Yes. I'll be going into 1 more IVF cycle soon in hopes of creating more normal embryos. Jenna, we basically are the same person. So I was right to say that I thought I said, hi, I'm Dr. Aimee. Before we can do a transfer, my RE is strongly recommending laparoscopy to check for endometriosis. HSG showed something that looked like scar tissue near my left ovary. Both tips. What the heck is going on here, you guys? Looked open. If I was your patient, would you recommend Receptiva first or go straight into laparoscopy? Love your show. Thank you. Yeah, so this is the thing. You worked really hard for your embryos to do both the ERA and the Receptiva, do them on the same day. So ask your doctor to prepare you for a mock embryo transfer cycle, which is basically like you're doing a transfer, but you're not. Rather than showing up in the IVF lab to get a catheter in to push embryos into your uterus, you get a catheter in to pull cells out. So it kind of sucks, literally, as a test, because it does cause pain. I give my patients 1 Valium and 1 Tylenol with codeine 30 minutes before, and I tell them, put the rest in my pocket. I'm just kidding. I don't do that at all. That would be totally illegal. And you can tell by my energy, I'm only on uppers, which is my coffee here. So I would absolutely do implantation testing, no doubt about it. I would consider laparoscopy. Your doctor is being so careful and cautious to think about all of those things. And then that magic line, ask your doctor, what have you ruled out? You've had 2 miscarriages. I don't need to point that out to you. I know you know that. But with 2, you have to ask yourself, should I also be doing a hysteroscopy at the same time as the laparoscopy, even though I had an HSG? Have we ruled out a thrombophilia? Would I benefit from Lovenox? And even if you don't have any diagnosed thrombophilia, ask your doctor, would empiric Lovenox be something that they would consider? So look at all the angel stuff. Look at the angel workup. Make sure you've done it all. Ask your doctor if they, it sounds like you're working with like someone that's just on the same level as far as being extremely detail-oriented. So keep going. You're doing all the right things, and I hope you'll send me a message in the future saying, I'm past my 2nd trimester. So this question is from Ashley. Thank you, Ashley, for sending it in. I'm a huge fan of your show. Thank you for supplying this crucial information to your listeners in an enjoyable format. Thank you. My sister says I'm atrocious. She says I should stop talking, that my hair is horrible, and my nose is awful, but I've grown into it recently. I'm waiting on blood work and will write with case-specific questions soon. But in the meantime, can you tell me, I know you don't usually recommend birth control pills to start, but do you make any exceptions? I'm 39, AFC was 16, AMH in June of 2020 was 1.5. I went to a consult that they suggested this might keep my dominant follicles from progressing too quickly. What is the difference between mature and quality eggs? I know an egg can be mature, but not chromosomally normal, but can it be good quality without first being mature? I'm confused. Last question is, how big do you let the lead follicles get before deciding to do a trigger shot? I lost several eggs in my last cycle because they were not mature yet. The lead follicle was 20. Let me break it down. Question 1, birth control pills. Since it sounds like you've already done an IVF cycle, there's a reason why your doctors are saying, let's do birth control pills. you don't have to do birth control pills for very long. You can do it for 3 days, you can do it for 5 days, you can do it for 7 days, 10 days, 14 days. What happens is people use birth control pills in a way that may not be the best for your body. Like they do IVF and they have a spot for you like in 2 months. So they'll put you on birth control pills for like 30 days or more, because 2 months is 60 days. You guys can do the math way faster than me. But my point is that you can use birth control pills, but you just don't want to use a lot of them. So if they feel like that's a strategy that would work for you, I'm totally fine with that. But what bothers me is when people use the birth control pills for patients who have like 5 follicles and they use it for like 3 weeks. And how do you expect those ovaries to like listen to any type of signal you send them after those ovaries have been like, they basically had earplugs in the whole time, and it takes a while for the earplugs to come out. What's the difference between mature and quality egg? So a mature egg is an egg that has a chance to become a baby. A quality egg is an egg that has physical characteristics that, the embryologists describe as being good quality. So let's just flip it and say, what's a bad quality egg or poor quality? Sometimes you hear things like grainy, which doesn't always mean they're bad, or they have vacuoles, or there's soft shell, hard shell. There's lots of things about the shell of the egg that you can hear. But those are things that you can't know until the eggs actually come out. And that's the thing that there's lots of stuff, obviously. Like I could sit here and complain all day. Lots of stuff that totally sucks big time about being a fertility patient. Like if you have diabetes, you can check a glucose and you can do something about it and it'll improve, and like everything's fine. With fertility, you take supplements and you're like, how the hell do I know that this is going to work? Like there's no data point that guides us that it's working. And then you show up for these egg retrievals and like one cycle you have a great cycle, the next cycle you don't, and you're like, what the heck? Like I did the exact same thing both cycles. You see what I'm talking about. But at the end of the day, it's like you just keep showing up and eventually, hopefully, magic will happen. And that's what I do. I literally see the impossible become possible. I don't know that it's necessarily magic. It's basically science. But it's this belief that my patients are fertile and they're going to be successful. And we just got to keep marching along and doing all the things that we're doing and just always thinking about, what do we know? What else should we do? And what can we do that's in our control to increase our chances? I know that doesn't necessarily answer your question about a mature versus a quality egg, because I just went, woo, like that. But I hope that explanation helped. So as far as how big do you let the lead follicles get before deciding to do a trigger shot, my approach is to track and trend your levels. I look at estradiol, I look at progesterone, I look at the whole picture, I look at your age, previous cycles, and sometimes I push a little bit further than maybe someone else would, because I'm not scared. I'm not scared. I'm just not. I give you ganirelix or Recceptiva, which is the antagonist, on the night of the trigger shot, and then I also give it to you the next day. And then I can, get up on the morning of the retrieval and not worried that all the eggs have gone away. I bet you guys noticed that rhymed. Okay, so thank you, Ashley, for those questions. Those were great. So this is a question from Ellie. I'm 29 years old. I've been trying to get pregnant for 2 years now. After 1 year of trying, I went to a reproductive endocrinologist. Prior to that first appointment, my OB sent day 3 labs, all normal. We did a semen analysis, all normal. When I went to see the doctor, they diagnosed us with unexplained infertility. HSG, saline sauna, hormone, sperm, all normal. Fast forward to now. 3 failed IUIs, and we're about to start FSH, and oh my God, my FSH came back at 12.5. I freaked out. I freaked out that I probably had poor eggs, or even worse, ovarian failure. My most recent AMH is 1.55. Last year it was 1.83. My antral follicle count is 15. What do you think my IVF chances will be with 1 cycle? I'm hoping to have 3 children. Also, my husband and I did genetic testing and we're not carriers for any of the same diseases. Ellie, I think you're going to be just fine. You know why? I think you have 15 follicles, and sometimes it takes growing 15 follicles to get 10 mature eggs, to get 8 fertilized eggs as embryos, and to get 4 blasts, and to have 3 that are normal. So that's kind of how I would think your IVF pyramid's going to look. So go print out the IVF pyramid. It's in the What is IVF article on my website, draimee.org. Show it to your doctor and say, what do you think my pyramid's going to look like based on everything that you know about me? Your FSH level just says you're still a fertile woman, go do IVF, and you're doing that. Your AMH level says you're going to get lots of eggs, over 10 it seems, based on your follicle count, and you just want to work with a doctor who believes in your fertility. It sounds like you found one, because sometimes people encourage patients to do IUIs way too long. So my thing is, why isn't your IUI working? And it could just be you didn't recruit enough eggs to get the one that was golden, so to speak. Or maybe the sperm wasn't sparkling that day. See, I had to throw sparkle in there somehow. So my thought process is you're going to do great. Consider taking CoQ10 if you aren't already, and I bet you are. And then I would say that you won't regret doing an extra cycle to bank more embryos because you're so young. Those, embryos, you can use them when you're 40 to have your 4th or 5th baby. When I say that, people are like, who has 4 kids? I'm like, I'm crazy. Okay. So thank you guys for all your emailed questions. I appreciate all the time that you took to send them in. Go to asktheeggwhisperer.com to email a question for me to answer in the future. I'm going to be here again tomorrow, 4 p.m.-ish. I have to see all my patients and make sure I followed up on almost everything before I can come on here. So let's answer some of your live chatted questions. So let's start from the top. Here we go. So the first question I have is, what's the difference between ERA and Receptiva? So the ERA is the time. It's the amount of hours of progesterone your body needs in order for implantation to occur. The Receptiva looks at inflammation and infection and tells me, do I need to look at the fallopian tubes again to rule out a hydrosalpinx? The Receptiva tells me, is there a chance that this patient has endometriosis and I need to treat that before I do the transfer? It basically tells me, was the protocol the right protocol to use when it comes to the medications? Next question is, any information on why follicle numbers can drop from 1 month to the next? I wish. I mean, you would think that we would know. It would be pretty awesome if I could do some tests that would tell me the follicle count every single month for the rest of a patient's life. That would be awesome. Until then, I have to tell patients to come in, do a follicle count, and then I'll be like, it's 6. It was 10 last month. I wanted it to be 13 because your AMH is 1.3. Go home, come back. Next month, yes, waiting was worth it, right? Until then, we have to check FSH, estradiol, AMH, look at the follicle count, and then decide, is this a good cycle for us to move forward with? So one of my mantras is, when your period starts, think of me, come on in by cycle day 3. This way, I don't have a patient who emails me on a Monday that her period started on a Friday and she thought she was bothering me. No one ever bothers me by telling them that their period started. They only bother me if they don't tell me because they think it's going to bother me. And then I'm like, you're bothering me. Okay, next question is, ERA test the uterus. Oh, someone is answering that question. Do you need to have BCL6 tested? I had Receptiva and my result is 1.7. My RE said it's normal and I don't need Lupron. What does it mean? Is this correct? So I think it just depends on your whole history. So BCL6, or the H score, it's a histologic score based on the amount of the stain that they use to look at the cells. So at 1.7, it's barely elevated. I wouldn't sweat it. But if you haven't had an HSG to rule out a hydrosalpinx, that's one thing that you can do. The other thing that I would do in a case like yours is just add a whiff of Femara. Femara is also known as letrozole. So this is a steroid that you can take during the phase of being on estrogen before you start progesterone. And that's been shown to be helpful in a case like yours. If you've never done a transfer before, just add 5 days of Femara, 2 tablets per night. Ask your doctor if they would consider that. And there are some research studies that show that that can help with implantation too. So if your doctor hasn't found those studies or been exposed to that kind of stuff or done it before, I would say most doctors have. So you wouldn't be telling them to do something that they haven't already heard of before. So the next question is, can I take NyQuil the week before I start IVF? And the answer is yes, you can take NyQuil. Next question, how much CoQ10 do you recommend? How much of each supplement do you recommend? So when it comes to CoQ10, I recommend 300 to 600 milligrams per day. That seems to be a good amount. Sometimes I actually recommend higher doses, 600 to 900. I think there was a study looking at 1,200 milligrams. That's a lot. That's a lot of pills to take. Okay, so a fertility, I know I asked what an MOT is. So a fertility MOT is same as AMH or antral follicle count test. Cool, I never heard that term. For men, it's a motility test. Okay, Pratima is saying, does a positive HPV result on a recent PAP negatively impact an existing pregnancy? I'm 11 weeks along. And the answer is no. I would just follow up on it, and maybe your doctor has a plan of another pap smear or HPV test in 3 to 6 months or something like that. Next question, is it possible for you to have a gestational carrier and still not have success with FET even if you have PGS embryos? So I think what you're asking is, can you transfer to a gestational carrier and also not have a successful transfer? Yes. And that's because each embryo has a certain implantation rate associated with it. It could be 40%, it could be 60%, it could be 75%. And why, if it's 75% and 25% of the time it won't implant, there are these special interactions that have to occur between the embryo and the uterus that have to be absolutely perfect. And that's called nature. That's the magic. And the other thing is that with these genetic tests that we do, the resolution of the microscope that we have sometimes isn't strong enough to pick up really small genetic abnormalities. So while we think we're transferring an embryo that has normal chromosomes, it might not. And it might not be detecting abnormalities that could result in an embryo not being able to implant, like things related to genes, like implantation genes. We just don't have the superpowers that I wish we did. You would think after all these years of doing IVF, I know IVF is young, it's 40 years old or so. So I just wish we were further along in being able to get the pregnancy rate to 100%. I mean, when I tell people that it's not 100%, they're like, what? I know. I agree. So someone's asking me, what do you think of PRP? I think PRP is cool. I think that it could help the uterine lining. I wish it was the answer to ovarian aging. I wish it was like the Botox that you could inject into your ovaries and then your ovaries would sparkle after that forever. It doesn't seem to be, but hopefully one day we'll have something like that. How much HCG is good with dual trigger? So it just depends. If you did 5,000 units last time, consider 10,000. And I have not uncommonly gone up to 20,000, but it really just depends on how many follicles you have. And the reason it depends on how many follicles you have is that if you have like 20 follicles, not many people would give you 20,000 units of HCG because that would put you at risk for ovarian hyperstimulation syndrome. So someone's asking, let me take a drink of my coffee. What is the difference between 2,500 units and 10,000 units of Novoril? That's a big difference. So 2,500 is the minimum amount of HCG needed to mature eggs. That's what studies show. 10,000 may likely increase the number of mature eggs that you'll get, and you might feel a lot crappier after your egg retrieval. Your ovaries will be more swollen, the HCG will be in your system longer, so you'll feel crappier and you'll be more swollen and you'll feel like crap. Get my point? So for me, it's a fine balance between getting as many eggs as I can and having my patient feel really good after the retrieval and not hating me for 2 weeks. And that's called the pain of ovarian hyperstimulation. So talk to your doctor about why did you choose the dose of trigger shot that you chose for me? What other options were you considering and why? Easy. Okay, next question. Dr. Aimee, why is my doctor giving me hell about the HGH priming? Is this something that they just don't do? Do I suggest that he do it? He's not considering doing it. So that's the thing. Like a lot of doctors, and I totally get it, they want to do stuff that's evidence-based. Okay. The problem with getting an evidence-based study looking at HGH priming is that who's going to sponsor a trial like that? HGH is generic now. It's very, very expensive. So anecdotally, I think that there are enough of us doctors out there doing it that we're noticing that it can work in some patients. The downside is you could be completely and totally wasting your money, right? And it's a shot. I mean, it's a tiny shot, but it's still a shot, and shots can hurt. So I would say if your doctor doesn't believe in it and they don't want to use it, you can't make them do something that they don't want to do. But you can say, just humor me. You've heard of other people using it and they've had successful cycles, and see what they say. And if they still say no, I think it's okay. I think as long as you're taking NAD and not true Niagen, but the pterostilbene and the high dose CoQ10 and doing all the things with lifestyle and everything like that, I think you'd still be in good position to have a successful cycle, even if your doctor doesn't do HGH priming for you. Next question. I'm 33. I have POF and Hashimoto's. We're going to start IVF next month. I'm taking CoQ10 fish oil, vitamin D3. Is there anything else I should add? I'm doing fast walking and fertility yoga. Awesome. I would add strength training to that. I stopped taking DHEA because I had high levels after 4 months of taking it. I mean, that makes sense. When you take DHEA, your levels tend to go high or get higher. Can high thyroid antibodies affect IVF success? And I would say, yeah. I mean, if your thyroid antibodies keep going up and your TSH is hard to control, then I would say then perhaps it can affect your IVF success. So make sure your TSH has been stable before you put an embryo in. And that's something that you can talk to your doctor or your medical endocrinologist about. My TSH jumped from 1.3 to 2.5 within the 9 months of doing multiple egg retrievals and IUI. Should I be concerned that my thyroid levels jump that much? It's actually not that much of a jump. I wouldn't really sweat it. I wouldn't just rely on your TSH though. Look at your free T4 and total T3 and see what the whole picture is saying. Next question is a great one. I'm worried jogging will jeopardize an IUI procedure. I just went jogging. I used to soft jog. That sounds like something that I do. I soft jog over 3 weeks ago before the IUI, but now I'm scared jogging will mess up something. I'm 44. Okay, look, if you're worried and scared, guess what? Don't jog. Walk. Treadmill time. And if you don't have a treadmill, no big deal. Get some sneakers on. Walk outside. I wouldn't jog shame yourself. I don't think jogging is going to hurt anything. This next question is from Meg. I just turned 29. I had 3 failed FETs, and I'm now scheduled for an ERA. Do you think it will help us for our 4th transfer? I've heard good and bad things regarding this test. So the answer is I've only heard good things. I haven't heard bad things. The only bad things I hear about the nightmare stories of patients who aren't prepared for it and haven't been offered medications pre-procedure, because it is a very painful procedure. So I would ask your doctor about how they prepare patients for the procedure and just tell them to tell you the real deal in their clinic. Anyone that tells you it's not a big deal and it's just a pinch is lying to you. It is a sucky procedure. So I tell my patients to drink 2 glasses of water 2 hours before and don't empty their bladder at check-in. I also have an abdominal ultrasound ready to go so that if I pass the catheter and it doesn't go in immediately, I just pop the probe on and I know exactly where I'm going, and then usually I get in within like 2 seconds. The procedure itself takes about 3 seconds. It's a pretty sharp pinch. My patients report it who aren't on pain medications as an 8 out of 10 during those 3 seconds, and then it goes down to a 3 out of 10 after about 10 minutes. My patients who take pain medications say it's like, are you done? Did you start yet? So you can see the difference. Next question is, Dr. Aimee, I'm having headaches since the last day of my first period post-egg retrieval. Could this be side effect from the IVF cycle I just did? It's possible, or it could just be the stress and the trauma from the IVF cycle. The hormones are out of your system pretty quickly. So by the time you've done your egg retrieval, all the hormones are out of your system from the actual stimulation. However, your estrogen levels go up and crash down. That PMS that you get after an egg retrieval is one of the worst PMS experiences you could possibly experience. I said experience way too long in your life. And that period, man, is like a waterfall. It's like, holy shit. Do I need to go to the ER for this period? And I have had a patient go to the ER, even though I'm like, it's your period. She's like, the blood is coming. I'm like, just trust me. And she goes to the ER, and the ER doctor's like, it's your period. So my point is that what you're experiencing can still be normal for you. And that's the thing. Everyone's experience is different. So it's possible that your headaches could be withdrawal from the hormones. But I would say a cup of joe and Excedrin should make the headache go away. And if not, get seen and assessed. You don't want to sugarcoat or just like miss anything big picture, but it sounds like you're going to be just fine. So Dr. Aimee, are day 6, 6AB and 6DB good grade embryos? Yes. Do PCOS patients need a different follow-up when taking IVF shots? Why? Yes. So PCOS patients, I think of you guys as dangerously fertile. I never turn my back on you. I'm like, I'm going to see you tomorrow and then the next day and the next day and the next day and the next day. And then after the retrieval, I'm going to call you 2 times a day, literally. It's because sometimes I give you a small dose of medications, your ovaries don't respond very well. Sometimes I give you a small dose of medications and your eggs are like, hello. And I'm like, good thing I'm seeing you tomorrow. So that's what happens. So ask your doctor, why did you choose the dose that you're choosing? Well, first, ask them, have you optimized and helped me heal my PCOS? Why did you choose the dose of medications that you chose for me? When am I seeing you next? And what are you going to do to prevent ovarian hyperstimulation syndrome? And then certainly in patients who have PCOS, doing a frozen embryo transfer tends to be the best idea to let the ovaries heal before you pop an embryo in. So next question is, just getting started with an RE. Could you please give any tips for us who are out there just starting this journey? So far, I've been diagnosed with Hashimoto's and hypothyroidism. Yes, absolutely get your tushy checked from the beginning. And the thing is this, with COVID, it is so hard to relate to people over a video. I mean, I'm really funny, and it's like, that's all I really had to say there. But I don't think people get like how truly funny I am over video. And it's just hard for me to like express that. My point is that it is so important for you to own your medical records and make sure that you understand what's being tested. I love my patients because they get me. They're like, I say to them, these are the tests that I'm doing. And if you don't hear from me by this day, please follow up with me so that I can give you the results. And then we will schedule a follow-up call. For those of you who are out there and aren't in a system that does that, what you might be doing is just thinking that someone's going to eventually call you. And that's not how the world works, unfortunately. So get your tissue checked. I'll just break it down for you. It's super easy. Your period starts day 3, get your hormone levels checked, do a full preconception panel, and get your genetic stuff done that day. Go in for an ultrasound soon after, before your HSG, so that if there is something really, obvious about your tubes, you're not pushing HSG fluid in right away. Do that HSG between cycle days 8 through 10. Get your semen analysis done. Make sure the sperm is sparkling. If not, look at Ball's method and see what you can do to improve the sperm quality. After a cycle, like you have every fertility diagnostic test, basically, sure there's like probably 1,000 more, but the big picture stuff you're looking at. And then you go to the doctor and say, this is the number of kids that I want based on my hormone levels and everything that you've learned about me. What are the treatment options that I have for me? And what is the pregnancy rate associated with each treatment? And I would throw in, what would you do if it were me? And if it were me, I would tell you what I would do if it were me. I actually already do that for my patients. And then if they say like, well, I can't tell you that, you'll be like, well, what would you do if I was your sister or your brother or your cousin, So I hope those tips help. So, love it. Hi, Dr. Aimee. I was told to take 4 weeks of birth control to start my stimulation. I'm sorry. When I brought up ovarian suppression, my doctor told me to stop 2 days after 2 weeks. Do you think it's good enough? Yes. Thank God you asked that. Someone's telling me to do a comedy show. Love you. I will. I actually have written out a set. It's pretty funny, but my sister says it's not funny, but I think it's funny. So maybe I'll still do it. Next question. I'm 35 years old. AMH is 1.47. FSH is 9. First IVF cycle. I got 2 blasts, both abnormal. Second round, 9 blasts, 2 PGS normal, both day 6, 3BA. Thoughts on FET success? Doing a 3rd round now to get more, hopefully. I would say if you were me, if those embryos were with me, I would say probably at least 70% chance of IVF success with each transfer. That's pretty awesome. Congrats on that. And go do another cycle and consider implantation testing. And yes, my sister is very mean. I also have factor 5. Will that affect success if FET will be on Lovenox? No, I'm not worried about that. So good job with the Lovenox. Can you have ovulation symptoms and not ovulate? And the answer is yes. It's so cruel and so mean. Like you can feel crampy, you can feel like you're ovulating and not ovulate. And guess what? If that happens to you and you don't get a period and you're not pregnant 2 weeks later, get tested. Find out why. Do I have PCOS? Do I have hypothalamic amenorrhea? Do I have decreased ovarian reserve? You see? There's always an answer. Find out what the diagnosis is. What do you think about over-the-counter fertility booster pills? I think that CoQ10 is a great fertility booster pill. I think there are a lot of supplements out there that are great. Next question, can I take Menopur and Femara together? The answer is yes. What is the HCG level you like to see at 10 days post-FET? The lowest level I've actually seen that's turned into a healthy baby was 15. You heard it here, 15. How many follicles or eggs would you allow in an IUI cycle? It just depends on the story. If the patient's over 40, I have no problem if the patient ovulates 4+ eggs just because I know the viability of each egg. However, the more eggs you ovulate, the higher the chance that you're going to end up with cysts and feel like crap afterwards. So it's like, we got to have a conversation about that. However, in general, if a patient is let's say under the age of 35, ideally I don't want her to ovulate more than 2 eggs, but for a patient over 35, I'm still okay. Me personally, this doesn't mean that your doctor will be okay with it. 2 to 3 eggs I'm still okay with. Next question is, I have an AMH of 3.8 and FSH of 5.2 and estradiol was 85, all on day 3 blood work. I don't see the question though. My clinic says they stop ganirelix when we trigger. Is that risking me ovulating before retrieval? Now I'm nervous. I'm on day 7 of Sims right now. Yeah, it's just a style thing. It's something that I was taught. It's something that other doctors around here do. Not everyone does it. It kind of also depends on when you've been doing your shots, when your trigger shot is, and when you do the retrieval. Let me break it down for you. So let's say you've been doing your shots at 7 p.m. Let's say they assign you an egg retrieval of 12 noon, and then you do your trigger shot at midnight, and then you're doing your retrieval 36 hours after your trigger shot. But now you've been so long without ganirelix or your antagonist, guess what? I'd be scared that you would ovulate. So most clinics have a rule that if you are triggered past 10 p.m., then they'll give you the antagonist at the same time as the trigger. So that's just something to ask about. So the other thing is I always check progesterone levels so that I even give antagonists the day after the trigger shot too in cases like that. And there are patients who come to me because they've ovulated on their doctor every single time they go to retrieval. And guess what I'm going to ask them to do? Take the antagonist twice a day, 8 a.m., 8 p.m. to prevent that runaway egg. Those runaway egg, man, they really ruin my day. Next question is, any supplements important for the first time FET success on a medicated cycle? How soon should you start acupuncture prior to an FET? So yeah, I mean, my usual prenatal fish oil, vitamin D. And as far as acupuncture, start it right away. Don't acupuncture shame yourself. I have patients that don't do it at all, and then they just do it pre-procedure and post, or I should say pre-transfer and post-transfer, and they do it in pregnancy just so that they have more energy and have less pain. Question about Botox. Can I start it 2 weeks before IVF? The answer is yes. How can we know the implantation rate of the embryos? Thank you for that question. Embryo diamonds. Okay, you guys? So D is for the day the embryo was frozen or transferred or discarded. I is for the implantation rate per embryo. A is abnormal embryos. M is if they're mosaic. O is getting all the official reports. N is which ones are normal. D is will they help you make your dreams come true. S is what was the sperm on the day of the egg retrieval. So now you're asking about the I, but you're indirectly asking about the O, and the O is official reports. You got to get the official reports. Talk to your doctor about the official reports and say, what is the implantation rate per embryo that I have here? You need to know the grade of each embryo and understand it. And don't go, I mean, obviously we all Google everything, right? Like that's what we do. But your clinic's grading criteria could be totally different than your friend clinic's grading criteria. So sometimes you might get like super bummed out about the grade of your embryo when you should be super stoked. I'll give you an example. Like for some patients, they're told that their day 6 3BB is crap. And I'm like, huh? That's not like in my clinic, that would be a really good chance of pregnancy. So I wouldn't get too upset about what you read about online, but talk to your doctor directly about your embryo diamonds, okay? What are early signs of implantation, and do you recommend a specific pregnancy test for early testing? I should come out with my own test, and I don't recommend a certain test. I have a test in my office that I give my patients if they don't have tests at home. But as far as early signs of implantation, it just totally messes with your head. You could feel nothing at all and be pregnant. You could feel everything and not be pregnant. And it's just a total mind F, if you know what I mean. Some patients report a slight headache. They report breast tenderness, nipple sensitivity. They report this feeling that their period's going to start like any second, but it doesn't. Sometimes they have spotting. They report this like really dull, low down back pain. Some people feel like it's almost like pain, and they call me freaking out like something's wrong. And I'm like, no, it sounds like you're pregnant. But those are kind of the early implantation signs that people get before a positive pregnancy test, sometimes. And if you don't, it's not a big deal. Next question is, I have an AMH of 0.4 and I have a doctor that wants to try a different protocol. What supplements do you recommend to help with low AMH to help with egg quantity and quality? I have one canceled stimulation. So I would do HGH priming, consider all the stuff that I've talked about earlier on the show. And someone's saying I pronounced your name correctly. Why, thank you. Okay. Next question is, how do they test egg quality? I'm 29, 10.8 AMH, clear tubes, regular cycles, unremarkable ultrasound, husband's sperm is good. It's just so hard. We can't test egg quality. It's kind of like you don't know what you're going to get until you bite. Wait. Life is like a box of chocolates. You don't know what you're going to get until you bite into that chocolate. I'm sure you guys can do a much better job than me. And that's the hardest part. Like men, you just have a cup and you like give the cup and it's like, this is your sperm. And for us, it's like, you got to shoot yourself up with shots and then pay tens of thousands of dollars and then do tons of ultrasounds and do a surgery to find out. There has to be a better way. If any of you are willing to dedicate your life to finding that way, please do and let me know, because there has to be a better way. Next question is, the 5CB really a poor quality embryo? And the answer is, I would consider that a poor quality embryo in my lab. However, ask your doctor, because your doctor might say, we have pregnancies with this quality all the time. So it's not fair for me to be like, that's not a good embryo. But it's fair for your doctor to give you the truth and complete transparency about that embryo, because then you need to ask yourself, should I freeze more for the future? Next question, what kind of side effect do the ERA medications have? Do you tend to put on weight during the ERA cycle? So the ERA cycle is just like doing a transfer, except you're not. Same meds. And estrogen doesn't have calories. That's supposed to be funny. It doesn't. They're pills, but they make you feel like you're eating calories because your metabolism is different, how you see food is different. Sometimes you're way moodier, sometimes you have insomnia, you're in this estrogen fog, and you're overall annoyed. So it's super important to communicate with your care team about how you're feeling, because we can make adjustments to your meds, okay? Next question is, this is Samra. Hi, Dr. Aimee, I'm 28, lost an ovary due to a cyst. Now I've been through 4 IVF cycles. My AMH is 0.2, FSH is 6. From 4 cycles, I have 1 frozen. What could be the best protocol for me? So I would strongly recommend adding HGH if you can. High-dose CoQ10, like I've talked about in the other supplements. And I would consider a hybrid protocol combining Femera with Menopur. Perhaps that's kind of what I would do, an antagonist natural cycle start. Let's see here. Okay, guys. I've been at the office literally since 6 a.m. this morning, and I love you guys. I could be here the rest of the day, but I still have to call my patients and give them all their trigger shot instructions. So my patients come first, you guys come second, but I love you all, so I'm going to sign off today. I'll be back tomorrow, and I hope you guys keep sparkling. There's a reason why I said sparkling. Keep sparkling. Keep making magic happen. And don't give up. Keep showing up. Keep tracking and trending your levels, and keep believing, because I certainly do. And that's why I'm here, and I'll keep showing up too. Okay? I love you guys, and have a great night. And I'll see you guys here tomorrow at 4-ish. Peace out. Love ya.